Anything that you say to a patient before an event occurs will be treated as an observation. And anything that you say to a patient after the event will be treated as an excuse.
You're listening to the Dental Protection Podcast, and it is my great pleasure to be your host for the very first episode of this channel's relaunch. The Dental Protection Podcast will bring you global voices from our global organisation, all aimed to ensure you're informed with the latest information and what's available to you as members. This is the In Dentistry series, where we explore some of the challenges in dentistry today and discuss some possible solutions. My name is Dr. Noel Kavanagh. My own professional background is in general dental practice, where I worked for over 20 years as both an associate and principal dentist in the UK and Ireland, and I now work full-time as a senior dental educator in Dental Protection's risk prevention team. Today, I'm absolutely delighted to be joined by someone who needs very little, if any, introduction, Dr. Raj Ratan. Raj is Dental Director of Dental Protection. His portfolio career encompasses general dental practice and Strategic Associate Dean in the London Deanery, Senior Dental Legal Consultant, Policy and Professional Advisor, Independent Non-Executive Director, Author, Examiner, International Lecturer, Speaker. I could go on. In recognition of his services to dentistry, Raj was appointed MBE in the Queen's New Year's Honours List. So Raj, I'm absolutely thrilled and delighted you could join me today to kick off our dental podcast channel. And I thought it only logical really to unpack a fundamental reason for dental protections existing, I suppose, the raison d'etre, the whole area of risk. As members and GDPs, general dentists ourselves, I think it's fair to say we can empathise with the realities of dentistry at the coalface in the clinical trenches, so to speak, and just how challenging it can be, navigating all the different risks that practitioners can face. There's exposure to, different potential hazards, I guess, be they physical, chemical, biological, psychosocial, and all the other risks. I mean, there's operational risk and compliance risk. There's strategic or business risk, financial risk, accident risk, and even I think just the risk of a patient complaint or claim. And I've heard you use the phrase or term risk intelligence in various lectures and articles before, and I think our listeners would find it interesting to hear your take on this.
Noel, thank you very much. And thank you very much indeed for that very generous introduction. It's a great pleasure to be discussing this topic with you today. We've done a few things in the past, Noel, and I've always enjoyed my conversations with you. But just before I get onto this question of risk intelligence, it was interesting when you went through your list of different risks. And if my memory is correct here, I think you said operational risk, compliance risk, you mentioned business risk, financial risks, and accident risks.
Yep.
I think those are the ones that you mentioned, but I just want to add one other one, if I may, please. It's one that is sometimes easily overlooked, and it is reputation risk. If we were to take the risks that you've mentioned, the sort of generic areas, include reputation risk amongst them, then we've basically got 6 areas. And I always imagine these 6 areas to be the faces of a cube. Yeah, so like the face of a Rubik's cube almost. Now when you're in practice, every patient that walks in through our door and every patient that we treat has a unique combination of risks. And the way that I see it in my mind is you have this risk cube in your hand and you just mix it up slightly and you get a unique risk blend.
Yes.
And when the next patient comes along, you mix it up again and you get another blend. And there are millions of different blends. And every patient that comes to us has a slightly different blend. And I call that the Rubik risk cube. And, for what it's worth, I think it does clarify how the risks and also the risk management needs to be patient specific. It highlights to us that every clinical situation that we come across with a patient is unique and different. And we should look at it exactly as you would look at a Rubik's Cube with so many permutations of those 6 risks. You mentioned risk intelligence. Going back to your question now, you mentioned risk intelligence. It's a phrase that I've used and probably used more in the last couple of years, and I'll tell you why I've adopted it. It's not an original phrase at all. It's a title of a book which bears the same name. And risk intelligence to me is the bridge that we recognize as a bridge between intellectual intelligence and emotional intelligence. So we know that in clinical practice, dentists need both these intelligences, and the bridge between them is risk intelligence. It's the ability, I guess, to deal with risk and uncertainty and to estimate probabilities accurately.
Yes.
It's about being able to gauge the limits of your own knowledge, knowing what we don't know, and being confident when we do know, and that allows us to then remain in control of the situation.
And Raj, do you think that our perception of risk can sometimes be distorted? Perhaps our perception of a risk versus the actual reality of that risk, that can be different. Do you have any thoughts or views on that?
Yes, it can be done. I think this is very interesting in a way. This is precisely why we need to use this term risk intelligence, because we need to think rationally about risk. So the first thing to realize is that we make judgments quite often on an emotional level, as well as on a rational level. But we are often influenced by the emotional level, and we perhaps fear situations that perhaps we should not need to fear. There's a range of biases and that we all have when it comes to risk management. And these are grouped into a series of cognitive biases. I think there's over 300 in total, but there's just two or three that are very relevant to dentistry when it comes to risk. And we can have a little chat about those now, or you can come back to that theme a bit later. I don't want to direct you, Noel. I
No,
just
I think right, that'd be really useful because I know sometimes you read articles, you see articles about this. I think the term I've read is a climate of fear, and I'm thinking particularly maybe about early years or recently qualified dentists, and it kind of brings me back to this idea of what their perception of a risk is, and maybe what the actual reality is, and whether they're different, and whether this is tied up with what you've just mentioned there about different kinds of cognitive biases.
yeah. So I think what you're talking about here really is what we could describe as I guess as a risk perception gap.
Mm.
And I think this is what comes into play. When we worry more than the evidence says we need to, or less than the evidence says we should,
Yeah.
um, that creates the risk perception gap. It's kind of built into our wiring, and the chemistry of our brain. Our apparent irrationality is, according to modern science, as innate as the functioning of our DNA.
Okay.
I'm reminded of a gentleman called Professor David Ropik. I hope I pronounced that correctly. And he's done some work on this, and there's a reference to it um, in a number of our presentations that I've done before, which you may want to look up later. But he talks about the risk perception gap, and there are reasons for it. One of the reasons is on a particular type of bias, which is described as availability bias. So availability bias is the tendency to overestimate the likelihood of an event when there is greater availability of that event in the memory.
Mm.
So this can be influenced really by how recent memories are and how emotionally charged they may be. And of course, when it comes to clinical practice, we know that our overriding duty is to look after the patient and to care for our patients. So when things don't go as planned, if I can use the phrase again, those emotionally charged moments do create a emotional response, and availability bias comes into play.
Yes, and I think that could potentially have consequences in relation to perhaps something clinical like diagnosing or treatment planning. a patient comes in with a problem, and this availability bias may, it may lead us to think back on perhaps a very recent case that was similar. Perhaps something went wrong, and as you said, there was an emotional overlay that could certainly change our perception of risk, and possibly even the diagnosis or treatment plan. Going back to our early years colleagues, Raj, would you have any advice for them in relation to this whole area of risk and their perception of risk?
Yes, I think the first thing is, and you've used the word already, I think, and I think I find it very sad, Noel, that a feature of the modern practicing environment or the modern practicing landscape amongst a generation of recently qualified dentists nowadays is fear.
Mm.
And there was a fascinating paper, a very interesting paper in a British Dental Journal some time ago about this, which focuses on this particular theme. And dentistry is such a wonderful profession that I find it sad that we have a generation coming through now who are fearful about what they do. It takes the edge off the profession for them, I think. And it's a privilege to be part of healthcare. And dentistry should be an enjoyable occupation, but the fear often overcomes it. And we do need to address this, I think. It's the only way to really address it effectively is to bring into the education and training from a very early stage the ideas around risk intelligence and to actually look at the data and put this into some sort of context and not always to focus on when things have gone wrong, but to celebrate when things have gone well.
Yes, no, I completely agree, Raj. And what about the relationship then, I suppose, between the confidence and competence, and I suppose the whole area of experience then as well?
Well, no, I'm sure in asking that question, you've kind of touched on a hobby horse of mine. This
Yes.
confidence and competence. It's an area of great interest. Well, what we're talking about here is what is known as the Dunning-Kruger effect, named after two professors. I think one of them was a professor at the time, and the other gentleman was his PhD student. I don't remember which way around it was. I think Professor Dunning was the professor at the time. They're both professors now, and it's the relationship between confidence and competence and the perception that somebody has about their ability and their confidence when they're carrying out clinical procedures. And quite often what happens is that you can engage in a procedure and you do it, say, for the very first time on a patient as a young graduate, and when it comes out well, you look at the clinical outcome and the results, then they're very good, and the patient is happy, and you think to yourself, actually, that wasn't difficult at all. I'm clearly good at this. And then you repeat the procedure, and suddenly you find out that one day things don't go as planned, and there are complexities, and you don't know how to deal with them.
Mm.
And then, of course, your confidence drops right down. And the authors originally described it as, I think that they call it the valley of despair, where the confidence is so damaged because you don't have the competence to actually support it. So the way around it, I guess, the way not to fall victim to this is to always work in a zone where your ability in terms of dealing with complexity is matched with your experience, and you are in what is described as this flow zone. Yeah.
Yeah.
And it's called a flow channel. And as you become more experienced, then you can take on more complex cases, but you still remain within this flow zone. And that's a strategy and a path which I think is very, very effective and can serve one well, throughout one's career, from year 1 to year 30.
And Raj, do you think using maybe a mentor, would that also be useful to complement that approach?
I think that's a great suggestion. No, I think that's an excellent suggestion. I would agree with you, wholeheartedly. I think mentoring is a process that we probably underutilize in our profession. And I think it's always sensible to have somebody you can go to discuss things. And I would also just add in, choose your mentor wisely. Make sure that they are several steps ahead of you and not just one step ahead of you. You need somebody who has considerably more knowledge and experience. So they need to be several steps ahead of you, really.
Yeah, no, I completely agree, Raj. I think this idea, building up your skills over time and starting out, perhaps with more straightforward cases, using a mentor, you've discussed, and perhaps the whole area of lifelong learning, engaging in, high quality accredited courses, they can all be useful for building up that level of competence that we discussed. I'm going to put you on the spot now, Raj, and a little bit of crystal ball gazing, and maybe just ask to share your top, takeaway, I suppose, risk management tip for our listeners in relation to this whole area of risk, and what would that be? And I appreciate I'm putting you on the spot for just giving one top tip.
One top tip. Okay. So I'm going to split that question, Noel, into parts A and part B, if I may.
Okay.
That's a bit cheeky, I know, but it gives me the license to give you a slightly longer answer than perhaps you were hoping for. So let me do part A. So the first general observation I would make is to do with risk management for all situations in general practice. And my tip is this: anything that you say to a patient before an event occurs will be treated as an observation. And anything that you say to a patient after the event will be treated as an excuse. So if you're doing an extraction for a patient and the tooth breaks, and then you have to take a surgical approach, then if you say to the patient after it's broken, the reason it broke was because there was caries and the enamel and dentin were undermined and there was a high risk of fracture, is going to sound as though you are making an excuse.
Yes.
But if you were to say to the patient before the procedure, at the very beginning, if you were to say to the patient, let me explain the situation here. Let me explain to you the condition of his tooth. It's quite undermined, the enamel and dentin undermined, and there's a high probability that this tooth will snap as we try and remove it. And you will hear that sound. Don't be alarmed by it. Don't be alarmed by the fillet snap, because we will then adopt a surgical approach to remove it. Okay, now that way, if it does break, we can manage the complication and we can deal with it. Now, this way of explaining to the patient now becomes an observation. So that's kind of my number one message. Yeah, make sure that you present things in advance of them happening. In other words, no surprises. So in terms of risk management tools, which was the focus of your question, if I may put it like that, I would say that my preferred one is probably root cause analysis.
Okay.
So don't always look for the proximal cause of the problem. Go deeper and use, it's called the 5 why technique. Ask the question why 5 times. And by the time you've got the answer to the 5th why, that will give you the root cause of the problem. And if you address the root causes, then the situations won't occur again, or are less likely to occur again. If, however, you spend your time just analyzing the proximate causes, then the root causes never get addressed. So I would say that that is probably my favorite, or one of my favorite risk management tips, certainly in my clinical experience.
I think that's a super tip, Raj, and I think the whole area of reflecting and learning, I suppose, on mistakes or even near misses that may have happened previously. And on that note, I'd like to thank you, Raj, for all those insights and very practical risk management tips. Thank you for listening to this podcast, Risk in Dentistry. I hope you enjoyed it, and if you have, please do tell your friends and colleagues. If you're a member of Dental Protection and want to know more about today's topic, please look in the podcast description for further information. If you're new to podcasts, perhaps listening for the first time, make sure you subscribe to the channel to make listening in the future easier. You can access this podcast from all the major apps, including Apple, Google Podcasts, Spotify. For more information about dental protection, or if you're already a member and would like a certificate for listening today, please look for details in the description. I've been your host, Dr. Noel Kavanagh. Thanks again for listening.